My dear friend, so this is Dr. Jun Jiezhang from Nanjing First Hospital. In the next 1 hour, we will do a TAVI procedure for a typical BAV case with severe aortic stenosis. So let me introduce to my team. In my right side is Dr. Kong Xiangquan and Dr. Zhu Jiancheng. Actually, this is a elderly gentleman, 85 years old gentleman, presented with chest pain and also with shortness of breath for 5 years and worsen for 1 month. His comorbidity including essential hypertension and type 2 diabetes. And also there is pulmonary Swiss occupation lesions, but it has been diagnosed for 4 years. It's also stable. So clinically, it's benign. So in terms of the laboratory test, BNP is elevated, 591, and the eGFR is normal, 82 milliliter per minute. ECG shows it's atrial fibrillation with RBBB. And RV function presented is New York Heart Associate Class 3. After calculation, the syntax STS score is extremely high risk, 12.6%. Next. So this is baseline's TTE. You can see from the baseline TTE LVOT view, it's a typical. Also, a short X view, it's a typical bicuspid aortic valve with moderate calcification. And this show LV motion is normal. And also you can notice the apex hypertrophic cardiomyopathy, maybe due to the severe aortic stenosis. Next. And also in the four-chamber view, you can see there is a mild mitral valve regurgitation and a mild tricuspid valve regurgitation. Next. So in conclusion, from the TT echocardiography, this is a typical bicuspid valve with a severe aortic stenosis. The mean gradient is 71 millimeter mercury, and the velocity of maximum is more than 5.4%. And also with milder mitral valve regurgitation and the mild to moderate tricuspid valve regurgitation, dilated LA and the RA, and with normal LVEF value is 68%, and the mild pulmonary hypertension. Next. So CT analysis is very important for the TAVI procedure. So you can see it's a moderate severe aortic stenosis with KLC5. And also you see there is a typical bicuspid valve, type 1 bicuspid valve. There is a cariner at the left side. And also you can see the calcium volumes is 227 millimeter tubules. It's a moderate calcified. And in terms of the aortic diameter, it's not enlarged, only 32. And the annulus, mean annulus diameter is 23. And in terms of the LVOT 5 millimeter below the annulus, it's also 24 millimeters. So typically, it's from the CT analysis, it's bicuspid valve aortic stenosis. Next. In terms of the coronary obstruction risk, the left coronary artery high is 17 millimeter. Right coronary artery high is 40 millimeter. In terms of the SVOV is quite large. More than 30. So I think it's a low risk for coronary obstruction during the TAVI procedure. Next. So from the CT analysis, the peripheral artery is large enough with minimal calcification at the at the femoral arteries. So So from this CT analysis, I think the transfemoral approach is the first choice. So from this case, I think thanks for its type of BAV case, we can do the high implantation, avoiding touch, avoiding exceed the septal brain, avoiding touch, compress the left bundle branch. So this is my strategy.
Thank you. Thank you for your great experience. I noticed you have finished several steps. Please introduce your procedure step by step in detail. Thank you.
Okay. For this typical case, we still use a femoral approach. We insert the 20 French the sheath. And what we have done, let me show you. Actually, we have inserted the temporary pacemaker wire from the right jungle veins. And also we have successfully crossed the wire into the LV and explain with the pigtail. You can see the pigtail is in the LV and another pigtail in the aortic loop. From the hemodynamic, you can see there is a high gradient between the LV and the aortic loop, nearly 90 millimeter mercury. So it's a typical severe aortic stenosis. So I think next step I will insert my guard wire. It's a super stiff LandQuest wire, which will give us more support. So we have shaped wire tip, make it a double curve. Actually, from the echo, there is a hypertrophic of the LV, so which means left ventricular is smaller. So considering from the baseline, the echocardiography, there is a very little regurgitation. So maybe we should be cautious after balloon dilation. There will be a risk of the cardiac collapse. So we will, in order to avoid this, we should set up our valve. So according to the CT analysis, we decided to use 26. So the valve is already another method to avoid prevent the collapse after balloon dilation. I think we should use enough hydration for this case. And this now you can see I input advanced the 20 millimeter balloon just cross over the aortic stenosis. So at this time, I will do the rapid pacing with high 118. So then do the predilation. So 118 pacing. Okay, rapid pacing. The BP decreased, maybe to still a little high. Okay, good. Okay, a little sleep. Down. Stop pacing. Okay. Okay. We have successfully do the balloon dilation with a 20 millimeter balloon. After that, we will do the TAVI for this case. We have set up the 26 venous A valve. It's a self-expand valve. This valve is domestic, and also we have more than 5 years result show the durability of this valve, especially for severe calcified and the BAV cases.
Professor, I have a question. I noticed after predilation, the hemodynamic is stable. And how do you select the valve size for this specific BIV patient? According to annular parameter or according based on the supraannular sizing?
So I think for this case, actually in China, we have a supraannular sizing case. But for this typical case, actually, it's not so severe calcification. So this case, I sizing according to the annular diameter. The annular diameter is 23. So for this case, I will select the 26 valve.
Okay, thank you for your great experience.
Okay. Then go to the LAO.往前松一点点。
松。
好，回到正位置。好，绷紧。Okay. You see there is a little resistance when we cross the valve. So we try again. Okay, we successfully cross the valve. It's not so easy, but when I ask my my Dr. Kuhn to pull back a little, then facilitate the valve cross, facilitate the TAVI system cross the aortic valve. So I think maybe we should use another projection, maybe LAO 30, cranial 60. Maybe this view can separate the left and the right corner. 第一个
伸床，床往上伸。
So the valve deploy projection is very important for TAVI procedure. Okay, good. Let's take a semi for this case. 3个点要成一条线，先照给你。Yes, this is good. Okay, from this view, we can separate this bicuspid valve. So for this typical case, I will do the high implantation, avoid the risk of the pacemaker implantation. Okay, then we go to the AP caudal view. Caudal 13 with the LA 1 degree. And to make the wire, advance the wire. Yeah, good. Very nice. Very good. Then still go to the LAO 30 degree, cranial 70.
What's the one? What's the one?
标准一定要切线，把它给倒过来。针点床，针点床，
蒸汽头。
针点机头。Okay, good. 太大了，Okay. Release, deploy the valve. During deploy valve, I will do the pacemaker pacing. Okay, 120. Okay. 噪音。Okay, good. Okay, release. 114. Oh, a little. Yes, please. Okay. You can see the position is good. Release. Release. Okay. 到回收位了吗？
到了。
Okay. Stop pacing. Then we check the position to see is this a good position. 噪音机。I think it's good. What do you think? Can you go to the what level, the baseline of the Yeah, it's good. Yes, it's good. Good. Very nice. Okay, good. Okay, good. So we put the button of the aortic the TAVI procedure at the same level. Then we evaluate, do the CD again to confirm the position is good. And you see at this time the BP is good. I think a little high. What do you think? But it's good. This is what we like position. So at this time, I will try to release the valve. Then hold the wire. Yeah, hold the wire. We will hold the wire. Okay, good. At this time, I will push the whole system a little because it's high deployed. And do a task again. Yes. Good. It's good. Okay, one pacing. 114. 准备释放。Gently released. Okay, nice. Okay, good. Stop pacing. Wait, follow. Yeah. We pull out the whole system. Okay. Retrieve the whole system. Then we evaluate again. I think the position is good. Exchange with the pigtail. Facing to 70 degree. 70 BPM. Yeah, good. So next step, I think the position is good. Then we will exchange with the pigtail to evaluate the gradient. Then I will do a cine of the aortic root angiogram to evaluate the PVR degree.
Professor?
So I insert the pigtail into the IV. Go ahead, Dr. Gao.
Yes, a very good position. You are TAVI master and a very good position. And how do you reduce the jumping out risk and how do you reduce the diving into the ARV during the TAVI procedure?
Yeah,
What's your suggestion?
Yeah, I think it's a collaboration, teamwork during the TAVI procedure. So during deployed, I think we'll do the high speed, maybe like 120 to 140 pacing to stabilize the valve during the deployed, and the evaluator with the angiogram. And also, this is a typical BAV case, and also a high risk of the pacemaker implantation due to the baseline ECG RBVB. So our implantation degree, I think my intention is a high degree, maybe 0, just at the level of the aneurysm. So thanks, it's a BAV case. The superior aortic root system can anchor in this valve. So this is my strategy. So you can see after we check the position, we pull a retro, the guide wire, and advance the whole system to the aortic root of the big curve. So make the valve system more coaxial during the final deployed, avoiding the valve jumping out. So that's all. Thanks for your attention. So today we do a good result live demonstration of the TAVI procedure for severe calcification BAV stenosis cases. Thank you.